just really small on my screen right now for some reason. Um, oh, and now they just went away. I don't, okay. Okay, here they are. All right, so hi everyone. I apologize for the technical difficulty. I'm not quite sure what's happening on my end. But my name is Dr. Wayne Bentham, for those of you who have not been on our series so far. I am, hold on a second. I am the psychiatric consultant for the C-Learn project, and this is the fourth and the last of a series of Thursday afternoon or lunchtime webinars on depression and psychiatric management of depression. So for those of you who haven't been on these webinars before, I'm going to do a brief review of the things that we've covered so far, and then get into the last session, which is on topics of medication management for depression. So typically with these presentations, I do my best to get through the slide set efficiently so that we can get through the information, and then I'll leave some time at the end for any questions or discussion. Next slide, please. Right, so we saw session one, we started off with this idea of the collaborative care model. And just to quickly review, the whole idea is that we are preserving the relationship between a patient or client and his or her primary care provider. Hit advance, please. And inserted in there is someone called a care coordinator or a care manager. Advance, please. Whose responsibility it is to make sure that in between visits with the primary care provider, that any information about the patient is gathered. This care coordinator also works with this client to make sure that they are following up on their care plans. And in between visits, anyone else who's involved, this care coordinator can become kind of the center for a whole lot of information that can then be made available to the primary care provider by the next visit. Please advance. This care coordinator is supported by a consulting psychiatrist who holds the specialty information, who will discuss cases with a care coordinator to make sure that things are progressing the way they should, to make sure that evidence-based interventions are being done. Advance, please. And this care coordinator is also supported by some sort of registry function that helps him or her keep track of a whole bunch of clients, and that way we get a really active list, really get a sense of who's not doing well, who is doing well, but most importantly, making sure that no one falls through the cracks. Next slide, please. And so we talked about how this in some ways can represent a network of resilience, for a client that involves not only the primary care provider and the care manager, but community services or any other service that is involved. And what we represent here in this slide is what we've been calling our map of individual resilience for someone who is participating in the collaborative care model, particularly relevant for one of the main goals of C-Learn. Next slide, please. In the next session, we talked about symptoms of depression, and we talked about the difference between, excuse me, depression as an emotion and clinical depression, identifying that when we look at the symptoms of depression, they are emotional symptoms, thought or cognitive symptoms, and physical symptoms, and these combine to bring about a significant change or severe change in this person's function or behavior. And this is our model of what we call depression, major depressive episode, clinical depression. Next slide, please. We also talked about the cycle of depression, recognizing that there are a number of different factors that actually lead to this common pathway, final common pathway of depression symptoms. Anything from medical symptoms to psychosocial stressors. And the helpful thing about formulating a depression in this way is that if we were able to get a really good and complete picture of all the things that may be contributing to this person's difficulty with function and difficulty with depression, is that these then become all opportunities for intervention. And we can see already how this could map very easily into the collaborative care model for taking care of a number of different things and for taking care of a multidisciplinary treatment plan that can result from understanding how depression is happening in this way. Next slide, please. The next week, we talked about cognitive behavioral therapy, and we kind of moved from this model of depression to superimpose this on the main idea of cognitive behavioral therapy, recognizing again that their cognitive behavioral therapy is about recognizing thoughts, behaviors, and symptoms, and using this model then to bring about significant improvement from depression. Next slide. We also talked about problem-solving therapy in primary care as a direct intervention for managing folks who are struggling with depression, recognizing that very often when someone is very stuck in depression, they may have a lot of difficulty recognizing or actually getting started on solving some things that can be really, really important. And so we talked about, the 7 steps of problem-solving therapy. You talked about that it's a very present-focused therapy, and we talked about how you, as a person who's working with a client in this way, is holding on to the hope for this person as they get more practice about identifying problems that are solvable, creating a number of solutions, comparing those solutions, and then choosing one, implementing those solutions, and then seeing what happens. We also talked about how important it is to actually maintain the attitude that if this particular solution doesn't work out, it doesn't mean that there's a failure. It means this becomes another opportunity to take a closer look at what was attempted, to see what didn't work, and then move ahead. We also saw that if there are successes in implementing one of these plans, this becomes an opportunity to be extremely positively reinforcing to this person and to give them a lot of props for actually being successful. And so we move away from this language into this language of opportunity and actually helping this person be curious about why something doesn't work, building their stamina, therefore, for solving problems, and building the habit for helping themselves get through depression. Next slide, please. One of the main ideas of cognitive behavioral therapy is the power of thoughts, and that thoughts are based in our beliefs. And sometimes when we are depressed, there are certain beliefs that actually keep us trapped in depression. And all of these thoughts and beliefs actually inform our choices of behavior. So one of the main ideas of CBT is that if we are able to actually work with people's thoughts and help them test them out and help them actually replace them with more useful thoughts, that we could actually bring this person out of their depression, specifically because they are interacting with their environment differently. And I talked about the analogy that I typically use with my patients that, when we look at the world through the lens of depression, it is very different than the lens of non-depressed. And what that means is that we choose different behaviors, we choose different ways of interpreting things, and we choose different ways of interacting with our environment. Next slide, please. And so the whole process of CBT is making sure that of CBT is to become aware of the ways we're thinking and the ways of we're behaving, using that behavior to inform some sort of action to bring about some sort of change. Advance the slide, please. And so the whole idea is that the things that we're becoming aware of in the model of CBT are thoughts, emotions, and actions, coming up with new actions and learning new actions to manage those things, and in that way bring about an improvement in symptoms. Next slide, please. And so we connected the idea that CBT is actually a well-recognized treatment for depression. It is also very effective. And that there are certain techniques within cognitive behavioral therapy that have been successfully separated out, as in some ways as mini therapies that can be used to help to bring about improvement in behaviors and therefore improvement in depression. And so we talked about how problem-solving therapy is one of those. How pleasant event scheduling is another one. We talked about progressive muscle relaxation and also exposure and response prevention, particularly when it comes to managing anxiety. Next slide, please. This is just a reminder that CBT as a treatment for depression is well characterized, is well studied, and actually very, very successful. And in fact, at this point, I think CBT has the most studies and the strongest evidence for improvement of depression symptoms. Next slide, please. So today we'll talk about medication management, and while we are going to talk some about the actual medicines that are used to treat depression, primarily what I really want to make sure we talk about up front is making sure that we understand some of the behaviors that we as mental health providers and as care managers or care coordinators or even social workers, some of the behaviors and habits that we can develop to actually make using medications successful. I always like to remind people that I am working with in this way that we have to remember that use of medications is actually happening in the context of a life, that there may be a lot of other things that are going on in a person's life that's competing with whether a person takes the medication or not. And sometimes we can lose sight of that in kind of the structure of how we take care of patients in clinical settings. It's actually helpful to remember that, because if that, then we can actually try to create some situations that a person is on board with a medication plan. Next slide, please. So part of the expectation is that with some or you provide some degree of what we call psychoeducation. And what all that really means is talking with this person about what it means to have symptoms, what the treatment is going to be like, what some of the options are, and listening from that, some of the things as they're moving forward with this treatment plan. So in that process, it is actually helpful to have this model available. And in fact, I would encourage you to make a copy of this. And if it's not present in your CLEAR materials, I'll do what I can to make sure that it is. But it's actually useful to have this to actually give to your clients, to talk with clients, about this. Now, we have spoken earlier about using the PHQ-9 and how that is helpful to talk about in the language of talking about depression, how we can talk about depression without using the word depression and just focus on symptoms. This becomes another one of those tools that really helps, you can be really useful to help you talk with your clients about all the ways other things in their lives may actually be impacting them so that they're experiencing depression symptoms. And sometimes it can be really useful to help your client identify if there are specific things in these categories that are particularly impactful when it comes to their depression symptoms. Next slide, please. So when it comes to patient education, my hope is that you are comfortable enough now, at least going through the series, to have a really foundational conversation with someone about what depression is, how it affects behavior, body and thinking, what the options are for treatment, whether it's psychotherapy or medications. So all of this information that we have been getting over the past 3 weeks, it's actually meant to support you to talk in very easy ways and very comfortable ways with your clients about what to expect in terms of the illness depression and what to expect in terms of treatment options that are available. Next slide, please. Right, so if you get nothing else out of this talk today, I hope you get this. So when it comes to the rationale for using antidepressant medications or antidepressant treatment, there are two main goals that we're talking about. Advance the slide, please. So the first is the main goal of using an antidepressant is to improve symptoms of depression. So those things that you have identified on the PHQ-9, if that medication is effective, that medication will improve those symptoms. So this is why it's helpful to start with the PHQ-9 and then use it at certain points along the way to keep track of how things are going. Because if the medication is improving things, those scores should be getting lower. Advance the slide, please. And then the other thing is that the other goal is that there must be some improvement in function. Now, I am focusing on this and this for a number of reasons, because sometimes, for a very important reason, because sometimes in the intention to try to get as much information to our clients about why we're doing something like prescribing medications and to get all the details of everything in place, remember the fact that the main idea is about prescribing medications to improve symptoms and improve function. And this becomes a very direct, easy, and simple thing that you can say directly to your clients, and you can actually use this as a way of tracking over time about whether the medication intervention is actually effective. Next slide, please. The other thing to recognize too is that very often in your working with clients, they will have someone that they trust, whether it's a family member or whoever, or someone from another kid who's following up with you as their care manager. And one of the things at the very beginning, particularly when it becomes medications, is to do what we can to also help this person be on board with the idea of being prescribed medications, so that we can so a lot of the psychoeducation that you go through with your client can be used to add a member or anyone else that's supporting them as well, right? Very often, in the beginning, when the client will to either well some questions they may have, or they're willing to go through things, this person becomes just another repository of information and another repository of get over the beginning of treatment, particularly when it comes to medications. Next slide, please. Now, what I'm going to share with you here is something that I be prescribing medications for them. And the whole idea about this statement is to make sure that they understand that specific goals for prescribe the medication, and that there are things that we don't have. You are all aware that our clients are coming to us with a lot of history and ideas and ways of what. I remember when I was first involved with the regional project, years ago. This was a big thing because there is so much misinformation and therefore so much idea about what it means to be prescribed a medication that this may get in the way intervention that could be helpful for someone. So advance the slide, please, and I think there'll be 4 clicks. Okay, thank you. And so I literally say this to everyone that I work with initially with medication. The first thing I say is, yes, the main purpose for being prescribed this medication is to improve your symptoms and to improve function. Not about making you feel like a zombie. This is not about making you sedated and tired. It's not about making you feel not like yourself. If at any point it all work together on this medication, any of these things happen, you let me know. This accomplishes a couple of things. The first is it addresses what are some of the common myths about medications right up front, right? So that person is knowing and reassured that, okay, you're hearing what I'm saying, you're hearing what could be some thoughts that I'm having. The second thing it does is that it sets up this agreement. Hey, if for some reason you are experiencing any of these things in this process as we're working with the medication, you let me know, because that means either this is not the right medication for you or something else is going on, or we need to get clear about exactly what it is we think we're treating. So it sets up this idea that this is now a back and forth situation, and it sets it up front. All right, next slide, please. So this is years ago, but it is so relevant now. There were some colleagues of mine at the University of Washington who worked for Group Health Cooperative. And one of the things about group health is that they keep a lot of data, on the patients and clients that come through. And they found that even under the best of situations, when someone is prescribed an antidepressant medication, they're going to miss days taking it. Now, in some ways, when I see this graph, I laugh at myself because, I take some medications. So for example, I take a blood pressure medication, right? And I know that in a given month, there are at least 2 or 3 days where I've missed a dose for whatever set of reasons. And it sort of makes the point that even under the most ideal circumstances, that, when it comes to the habit of taking a medication for an illness, there are things happen, the person misses a dose. So I always laugh at myself in that this was a study that actually cost a fair amount of money to kind of prove and show something that we know already happens. But the point that I'm making here with this is that this becomes another aspect of being prescribed medication that you can talk with upfront about with your patients or clients. Next slide, please. And so one of the things that I typically ask someone in the beginning parts of prescribing the medication is, as we're doing this right now, what are some things that come to mind for you that's going to get in the way of you taking this medication? And you will be surprised sometimes by the things that come up. But what I like about this approach is, one, it brings up the issue up front, and two, if this person gives you a list of things that they think are going to get in the way, very often these are also very lined up with a lot of the things that may be impacting their lives when it comes to depression. So advance the slide, please. So it can be any of a number of things, anything from fear of side effects, so that becomes a point of discussion. The cost of medications, that's a really, really big deal, particularly in communities that we are trying to help be resilient from things like disasters. Family members, it could be that this person may have a family member at home that has some very specific ideas about this person taking the medication. And so they're anticipating that this is going to be something of a problem in their family, and they may avoid, the problem by just not taking the medication. But you can something that can be an opportunity to troubleshoot what's going on. Getting to the drugstore. All sorts of practical things can come up. So the more that we could actually help this person anticipate what are some things that may get in the way of successfully taking the medication, the more opportunities we have for solving those issues, and the more opportunities, and therefore the more likely it is that this person will remain adherent to a medication plan. Next slide, please. So as a care manager, it is going to be important for you to become familiar with antidepressant medications that are available. Now, by familiar, in no ways do I mean that you need to become an expert in the psychopharmacology of medicines and how they work. But in your everyday lives already, you've probably become aware of, medications that are used for depression. You probably know some names of some of these things, if only, just being exposed to television and the ads that are there. But the whole idea here is that if you're able to at least have an organized understanding and an organized set of knowledge about antidepressants, it becomes that more effective to have a good conversation productively when something is not going as expected, because it is the expectation that you are going to be the first contact, in this collaborative care model if something isn't working out. Next slide, please. So this slide just kind of reiterates in some ways and maybe expands in some detail what I was just talking about, helping patients and their providers identify potentially inadequate doses, ineffective treatment. You as the care manager, as I mentioned earlier, will be kind of the first line in hearing when something is not going wrong. And so if you can have an organized set of information, organized set why things may not be working out, it becomes that much easier for you to not only talk with your client, but also talk with their prescribing provider so that something can be changed if it's not working out. The other thing that will happen too is that as you're being supported by this consulting psychiatrist and talking, about the care of these clients, you will start to get an idea of how to start to think about the medications in this functional kind of way, and you will actually develop the skill of actually talking very easily about what to expect or what not to expect, as far as medication treatment is concerned. Next slide, please. So when it comes to prescribing antidepressants, particularly for depression, there are some things that are worth calling out specifically. So if a medication is going to be chosen to treat depression symptoms or a major depressive episode, antidepressants are what are used. They're not tranquilizers, not the benzodiazepines, not anything else, antidepressants. So we're going to go through in some detail, what these are and how they're different. And another important concept is having an adequate dose of a medication to bring about improvement. And some of this you will learn with experience. But what we do know is that for some medicines, depending upon the intensity of depression symptoms, there are some dose levels that work better than others. All right. Another concept here is that when we're starting a medication for the treatment of depression, we always start with the low dose, and this allergic reaction to it, and 2, doesn't have any other type of unexpected reaction to it, and 3, maybe also getting this person on board with the idea of taking the medication, and then advancing that dose, to what we think is actually a therapeutic dose. So this is where you, again, become really, really important as your care coordinator or care manager, because this is one of the ways that you make sure that you support care and make sure that care is advanced. It is expected that in your discussion with the primary care provider or consulting psychiatrist about a treatment plan that includes medications, that you are aware of how long has this person been on this medication and what dose that are they on. And then again, if you have a registry function that is helping you support this, and this is the type of work that's expected of you, it becomes easy to do that. As a general rule of thumb, when we first start a medication for depression, it's usually around the 4 to 8 week mark that we get a sense of whether the medicine is effective or not, or whether symptoms have improved. And it's usually around that time that we as psychiatrists or a primary care provider would expect that we would change a dose or modify a dose as needed. Next slide, please. So some medications to avoid, and I mentioned this briefly earlier, benzodiazepines. So we know what these are. The Xanaxes, the Klonopins, the Valiums, the Diazepams. They are not antidepressants. They are medicines that actually have high addictive and dependence potential if they're not used correctly. You may come across patients or clients who are already prescribed these. And if they're already prescribed them, the idea here is not to just take them off of them. The idea here is to maybe get some more information about how long they've been on them, what they were prescribed for, and then support your primary care provider about whether this is appropriate. Remembering, of course, that one of the things that we mentioned, I think 2 sessions ago, that people with depression may often have other psychiatric illnesses like PTSD, like anxiety, like panic disorder, and things like that. That being said, I'll also make the point that benzodiazepines for the treatment of PTSD is actually really not indicated either. But again, just so you know that, so that if that issue comes up, with what a patient or a client that you're working with, it can generate a discussion. Next slide, please. All antidepressants, regardless of their underlying mechanism of action, have a similar level of effectiveness. What we mean by that is the extent that antidepressants across the different types of them, if we look at populations of people who are taking antidepressants, the average response rate is about 30 to 40%. Now, I said the average response rate because 30-40% may not seem like a lot, but 30 to 40% improvement in symptoms for someone can actually make the world of difference. Also remember that in the context of the care for someone with depression that's taken a medication, that medication is one part of their treatment plan. Certainly community interventions and psychotherapies that we've spoken about can also have an additive effect to bring about improvement in depression. Next slide, please. So the FDA approves certain categories of antidepressants, and what's highlighted here are just that. This is meant to be an information slide for you. You're not expected to memorize or anything like that, but it's helpful to know what the generals are. So everyone is aware of things called the serotonin reuptake inhibitors. There are things called the SNRIs. The other medications that don't fit in that category, like Wellbutrin, and most people have heard about that, for smoking cessation, for example. And then there are the older antidepressants that are called the tricyclics, things like amitriptyline and nortriptyline, that you may come across. Particular clients or your patients who are struggling with issues with chronic pain, for example. A lot of primary care providers may use this to try to improve that. And also for your patients that may be struggling with sleep. A lot of old school primary care providers will use, some of these tricyclics to help with sleep. Next slide, please. So, this slide and the slides after that are meant to be purely informational for you and to be reference points for you. They list out names, not only but the generic name of the most common antidepressants, what's the usual dose range, what's thought of a therapeutic dose, some specific comments, that could be helpful as you're triaging things with your clients. Next slide, please. Right, and this is another slide of the same thing. So I'm hoping that we are able to get this type of information to you in paper form. I haven't gotten it already, so that you have that as a reference. Next slide. And this kind of describes some of the other medicines that may fit out those categories. Next slide. And again, the tricyclic antidepressants. Next slide. Okay. Now, one of the things that that you will be supporting, particularly in the beginning of treatment, is once your primary care provider has made a choice around a medication, it can also be helpful to think about what are some things that inform that choice. So certainly, the type and the intensity of symptoms is one thing, but sometimes it can be helpful to get a history from one, if they are aware of other family members who have struggled with depression, and what medicines that family member may have taken that would be helpful. Knowing the genetics, that could be a helpful place to start. Some patients may come to you, or some clients may come to you with some ideas about medicines that they're taking already, and you can help them remember that, so they can talk about that with their provider. Some providers, have with the first ones that they reach for. And a lot of the choice also has to do with what's known as side effect profile. For and taking medicines for other conditions. And we need to be aware and be careful of any potential drug interactions. So again, this is not meant to have you be primarily responsible for the decision making, around antidepressants, but this is some of the thought process that can go into that. Next slide, please. And what this graph, I put through this graph in here just by way of highlighting the fact that when it comes to, one of the common things to think about when it comes to prescribing antidepressants is effectiveness or therapeutic effects versus side effects. Now, very often when it comes to being prescribed an antidepressant, if someone is going to experience a side effect, it usually shows up in the beginning, within the first week or so, if it's going to happen. And the more common things like nausea, some people may experience some excessive sweating. And all that's happening because, particularly for these serotonin-based medications, this is happening because there are only serotonin receptors in the brain. There are serotonin receptors all over the body, particularly in the GI system. And so the person that takes this medication, all receptors are being pinged, by this adjustment happen. And those common things usually go about in a multitude of therapy. Is you just starting the medication, getting to what you think is an effective. It's usually within that 2 to 4 week period that a person may start to experience for themselves subjectively improvement in their symptoms. So that's just a graph to kind of help you kind of visualize that in a way. Next slide, please. So I mentioned, that there are side effects to medicines and antidepressants that can happen, and again, maybe thinking about the practicality of what it means to be a care coordinator, depending upon how this is set up, you may be the first person that your client actually says that they're having side effects to. And so as part of your plan of support, for a client in this collaborative care model, it's going to be important for you to have reliable ways of communicating not only with your client, but also with that client's primary care provider and with your consulting psychiatrist, so if something like this comes up, you can actually support communication of what information is happening, so that a decision can be made as quickly as possible. And that decision may mean, cutting back the dose of the medication. It may mean switching from that medication to something else. It may mean stopping the medication. But again, the whole idea here is that very often you're going to be the first point of contact, and it's going to be important for you to have reliable ways of communicating with the providers involved. Next slide, please. Now, many of you may have heard about over the years the risk of increased depression and the risk of suicidal ideation when being prescribed certain types of antidepressants. This is something that happens, and it is something that is real. It's important to remember a few things. The first is it does not happen with everyone, and so far what we do know is that it tends to happen in younger people who are prescribed the medications. The other is that this has happened with one medication doesn't mean that it's going to happen with others. So that is the reassurance that you can give someone. And of course, the expectation is that if one of your clients calls you being concerned about suicidal thoughts or increased suicidal thoughts, that you have in place an action plan and a process for assisting this person to get help, whether it is making a quick call to the providers involved, or making a call to 911, or contacting a family member, but having some plan in place for what is your next step when you get a phone call from someone expressing that they are experiencing suicidal thoughts. Next slide, please. These next couple of slides were meant to really kind of give you an idea of examples of some decision making when it comes to depression, and then what to do with medications. So I'll go through the first part of this just by way of an example. So in the first column there, we see that in week 1 to 4, someone has stopped their medications, and in that visit you screen this person for the depression score, and they're scoring an 18. And so the question then becomes, well, what's going on here? Did they stop the medications because they were having side effects? Did they stop the medications because they couldn't afford it? Were there other things that were going on? And then So in that of triaging what's happening, providing some degree of education to the patient about what may be happening, and then recognize that this may be a situation where you would definitely want to discuss this event with either your consulting psychiatrist or primary care provider. So, each one of these lines is kind of a way of describing, what are some decision-making points and how you would go about, getting help and support for your client. Next slide, please. Okay, actually, you can skip this. Next slide, please. And this is another example of kind of continuing on that same vein before. And here, for example, at week 8, here's someone who's been taking fluoxetine or Prozac 14 milligrams a day, and their PHQ-9 score is now a 4, but they're presenting with the problem of a side effect. And so, your role here again would be to take this information and communicate it with their providers. But, just for your information, so, the decision-making point there would have to do with whether we thought the sexual side effects was thought to be due to the medication, what options they are instead of using the Prozac to address that. And, it's up to your primary care provider and your consulting psychiatrist to kind of to think about that, come up with a plan so that you can communicate that back to your patient or client. Next slide, please. So a few things to remember then about the medication management of depression. Remember that there are at least 20 FDA-approved antidepressants out there that can be chosen from. So the helpful thing about that is that if a person comes to you with a history of being on a medication that didn't work out for whatever reason, there are a bunch of other choices, and so this can become a point of reassurance, and support for your client. Another point here is that, we don't, going back to the idea that we are being prescribed these medications in order to improve symptoms and improve function. It makes no sense to be hanging out on a medication for 8 to 10 weeks if nothing has changed. I mean, if anything, the only thing you're doing is actually exposing that person to more side effects. So it's helpful to actually think about upfront, okay, well, what's my threshold, in working with clients to suggest to them that maybe we should be talking with your providers about changing your medication. And I think 8 to 10 weeks after an initial starting of a medication, is reasonable. And in fact, I would probably say, maybe 6 to 8 weeks and fall more on that side of it, because we don't want folks hanging out on medications that are not working. And we want to make sure that if things are not working, that we address that issue as soon as possible. Another thing to understand as a general principle is that over the course of treatment with antidepressants, the vast majority of patients out there are going to need a dose adjustment. And so we just know that that is a thing. And so if you're able to know that upfront as a general guiding principle, then we become less likely to have a bunch of clients out there hanging out on 5 milligrams of Paxil, just knowing that 5 milligrams of Paxil is just not going to do anything. And I say this from my own experience. I can't tell you the number of referrals or consultations I receive, particularly on the outpatient side, for someone who is being prescribed an antidepressant but it's not working. And it turns out that they've been on 5 of Paxil for the past 2 years. I think there's a lot that goes into that, that has to do with people accessing care and symptoms and things like that. But I think if we can hold in our brains up front the idea that the vast majority of people out there, when they're first started on an antidepressant, are going to need to have that dose adjusted, it decreases the risk of people just hanging out on low doses of medications that are ineffective. Next slide, please. It's always helpful to have what we call a plan B when it comes to the treatment of depression. Now, one of the things that we've been talking about is kind of the multifaceted and the multidisciplinary approach to the treatment of depression, and recognizing that being prescribed a medication is only one of a part of a treatment plan for the treatment of depression. right? So keeping that in mind, it's helpful for you as a caregiver, particularly when it comes to giving your client support in the beginning, to help them recognize that, yeah, we've successfully gotten you on a medication, but we also need to consider having you go through cognitive behavioral therapy, or working with me on problem solving therapy, or pleasant event scheduling, making sure that we have you connected with your other community agencies or your other providers, so that all of these things are being engaged at the same time to help improve your depression. But these also become candidates for Plan B, Plan C, Plan D if that medication doesn't work out. I'm also going to reiterate to you that in the beginning, when we talked about the collaborative care model and the IMPACT trial, which was the scientific study that proved that the collaborative care model was very effective, that for the people that were successful in that trial of the collaborative care, there were a significant number of patients who had not taken medications. So I think that's also important to remember, that there are a number of different types of plans for treating depression that don't necessarily have to include medications. And so this can really decrease the tension that can happen if something doesn't work out with this person taking a medication. We have to take it. But if there is some difficulty that persists about it, it could be that that would be a good opportunity to look at other modes of trying to help this person get better and help them get more functional in their lives. Next slide, please. Over time, as you're working with your consulting psychiatrist, this process of tracking depression symptoms, tracking failure to response, getting ideas about whether there are other diagnoses that are happening, this is all stuff that you will kind of learn kind of on the job as you're talking with your consulting psychiatrist. And, it becomes really interesting to try to think through, what are some other things that may be going on that may be getting in the way of this person getting better. Next slide, please. Now, how long should someone be on an antidepressant once it starts to work? As a general rule, particularly for someone who's been on a medication for the first time and it's successful, I usually recommend, depending upon the situation, anywhere from 9 months to a year. And the main reason for doing that and suggesting that is something I said earlier, which is, when we look at our lives through the lens of depression, we make different decisions and choices than when we're not depressed. So if we're able to successfully get this person to look at their lives through the lens of not depression, we want to give that person as much opportunity as they can to arrange their lives and their relationships in non-depressed ways, because if they're able to do that, then they're able to use their environment to actually decrease the risk of relapse. There are some studies, some pharmacological studies, and also some epidemiological studies that suggest that this time frame is helpful as well. But from a functional standpoint, that is actually the main reason, at least as far as I'm concerned. And then, of course, when it comes to deciding to take this person off of medication, this should ideally be done in consultation with their prescribing provider, and that a very specific plan be identified about how to do that, and how much to decrease the dose over what period of time, etc. Next slide, please. And we reviewed some of this. I'll draw your attention to the bottom part of that slide. It is also helpful to remember that depression is one of these illnesses that has recurrent episodes, right? And so, one of the things that we do know is that the earlier the depression episode in the course of a lifetime, and the more episodes a person has of the course of a lifetime, the more likely they are to actually have a depressive episode. So that's something that's helpful, and that may inform your prescribing provider's decision-making around whether this person needs to be on a medication like this for long. Next slide, please. So just by way of summary, when it comes to supporting your clients that are being prescribed medicines to help with depression, psychoeducation is very, very important. Again, it's very important to think ahead about things that may get in the way of this person being consistently adherent to their medication plan. So anticipate things like anticipate the idea that this person may miss doses. Use that to have a discussion about what things may get in the way of this person being adherent, and then those become those become things that become be created and addressed in the treatment plan. Um, the second thing is, when it comes to psychoeducation, always come back to this very simple idea, is that the whole idea of being prescribed a medication is to improve symptoms and to improve function. If those two things are not happening while this person is on a medication, then that situation needs to be addressed. The third thing is to also think ahead about what are some of the thoughts and the beliefs that someone may have about being on a medication that may get in the way of them taking the medication. And very often, they will not tell you about this. So again, these medications are meant to help you improve your function and to improve your symptoms. We're not trying to make you feel like a zombie or have you be sedated or to make you feel like you're not yourself. If any of those things happen, please let me know. And again, this will make the world of difference when it comes to helping folks kind of be more comfortable with you and more comfortable with their providers as they're taking the medication. Next slide, please. So, end of the series for CLearn, I just wanted to summarize a few ideas that have stood out across this 4 weeks. And the first is here again that we can actually physically represent what it means for someone to have a network of resilience around them that's informed by the collaborative care model. And the idea here in this representation is that here's a person who's been identified, who was activated and involved in their care, and also the recognition that there are all types of care that are important, equally important when it comes to helping this person recover and be resilient in a situation. Next slide, please. We talked about the cycle of depression, and that if we are able, that this becomes a tool that can be really helpful in helping your clients conceptualize what may be some things that are going on in their lives that is actually contributing to how they're feeling and how they're doing. And the more information we can get about these areas, and the more information we can get about how these areas are affecting them, the more opportunities we have to create successful interventions. Next slide, please. And I guess that is all for today. So I want to thank you for your time and attention over the past 4 weeks. I apologize again for the technical difficulty that happened earlier at the beginning of this session, but I hope you were able to find something useful. We have exactly no minutes left because it's 1 o'clock. But if you have some questions or some thoughts, I'm happy to stay after and address those. And again, at any point during this process, if something occurs to you that you think would be helpful for me to answer, feel free to send an email to me. I will definitely respond to that. So thank you for your time.
Great. Thank you so much, Wayne. That was amazing. And if folks that are still on the line have questions, feel free to shout them out if you have a couple minutes here past the hour. Okay, Wayne, it seems like people are logging off.
Okay.
But thank you so much for presenting, and we'll be in touch soon.
Great. Thank you. Have a good afternoon.
You too. Thank you.
Bye-bye.